Good morning. It's 7:30 and time to start our grand rounds. As always, the CME code is in the chat box, and we'll keep repeating it every 10, 15 minutes. It's my great pleasure to introduce this morning's grand round speaker, Dr. Justin Zachariah, who is a associate professor in pediatric cardiology at Baylor College of Medicine and Texas Children's Hospital. He's an NHLBI R01 funded clinician scientist in prevention of atherosclerotic cardiovascular disease by addressing cholesterol and blood pressure risks in children and vascular medicine. Dr. Zachariah's responsibilities include Texas Children's Hospital Heart Center co-chair of research, operations, and director of research for the pediatric cardiology division. He was privileged to be the first pediatric cardiology trained research fellow in unique collaboration between Framingham Heart Study and Boston Children's Hospital, where he was trained in biophysical and biochemical marker assessment and analysis, including circulating biomarkers of atherosclerotic cardiovascular disease, analysis of arterial stiffness, and atherosclerotic cardiovascular disease epidemiology. He leveraged these experiences, a master's in public health from Harvard School of Public Health to publish manuscripts about primordial and primary atherosclerotic cardiovascular disease prevention with tools ranging from epidemiology, cost effectiveness, non-invasive vascular testing, clinical outcomes, translational work in biochemical and biophysical biomarkers, and omic platforms. Multiple published projects prove expertise in genetic epidemiology and Mendelian randomization, arterial stiffness analysis, circulating biomarker analysis, pediatric dyslipidemia, and hypertension. Service commitments have included past chair and member of the Young Heart Cardiovascular Disease Prevention Subcommittee as it transition focused to a more holistic definition of atherosclerotic cardiovascular disease prevention, recognized invited expert on ASCVD, writing statements, as well as social determinants of health and award-winning innovations in provided electronic decision support tools. Dr. Zachariah, thank you very much for accepting our invitation. We are looking forward to your presentation. The floor is yours.
Thank you so much. Thank you so much for this opportunity. I'm happy to join you all today. And there will be a couple of instances where I'll be asking for your input, so please feel free to either put your answers in the chat box or speak up. Today I've been invited to speak about diagnosis and treatment of high triglycerides. And hopefully this is a topic that many of you deal with in your primary care and other specialty care clinics, and hopefully we can give you an approach and a method to think about this space. I have no relevant financial relationships with commercial interests. I do have a couple of research grants as noted earlier, and I will discuss unapproved and investigative uses of products, but I'll note those when I'm talking about them. So hopefully by the end of this presentation, you'll feel comfortable educating patients and families about the burden of pediatric dyslipidemia, understand and synthesize the centrality of lipoprotein lipase in high triglyceride pathophysiology, and identify the key role of insulin resistance in high triglycerides in the blood. So we'll start off with a little patient presentation. We should always start with our patients. Take a little historical digression where I may be asking for some of your inputs. Talk about what are classic cardiovascular disease risk factors, try to justify current lipid management in kids, and look over what is the current overview of management of these conditions. So a patient that I've summarized based on her actual history, an 11-year-old East Asian American female, was born at term and had a normal newborn screen, no previous hospitalizations, diagnoses, or surgeries. In her past history before seeing us, she's had 2 episodes of severe epigastric pain over the last few years. One episode woke her up from sleep. Workup reportedly included normal ultrasound but abnormal liver on her labs. Review of systems is otherwise negative. She's on no medications, has no medication allergies. Her family history is significant for a paternal aunt who had sudden cardiac death at age 29, paternal grandmother with high blood pressure and high cholesterol, but no other important relevant family history. Exam showed that her vital signs were in the normal range, her height and weight were in the normal range, and her BMI was at the 40th percentile. No xanthomas, xanthelasmas, or other skin findings, including acanthosis nigricans. I did not have a fundoscopic exam done while I was in the room. And her labs are, as you can see there, mildly elevated ALT, total cholesterol elevated at 211, normal HDL at 40, LDL of 103, triglycerides mildly elevated at 338 at that time, fasting, and TSH of 1.52. We'll get to her at the end. So a digression, a historical digression. What, who, where, what are we looking at here? Any takers? I love asking this question every year because the number of people who remember what this is gets smaller and smaller. So in the interest of time, I'll give you the answer. This is, that's right. Sitting on the left, I see a response here of Churchill. That's correct. In this picture, it depicts the meeting at Yalta at the end of the Second World War. And you've got Winston Churchill, Franklin Roosevelt, and Joseph Stalin deciding how to divide up the world at that point as they become victorious. And circled in red here is President Roosevelt, who has a couple of interesting things going on in this picture. One is what he's holding in his hand. Anybody want to point out what he's holding in his left hand there? You won't see pictures like this anymore. You can see that he's holding a cancer stick in his left hand, draped over his leg there. And so there have been rumors that recent residents of the White House may also have been smokers, but nobody took any pictures of it. And then the other thing you'll notice is the way that the president's leg looks. If you compare it to the way your leg looks as you're sitting down, his leg looks different. Scalloped out behind his knee there, almost like there's a lack of fullness in his thigh. Any takers on why that happens? Why does it look that way? That's right. I see a correct answer in the chat box. The president had polio, and due to polio had some muscle wasting, and therefore that's why his leg doesn't look like what your leg looks like. So here's the next point of our pop quiz. Did polio kill the president? Did the president die of polio? It turns out he did not. It came out of the clear sky, says the president's physician. He had death due to a cerebral hemorrhage. A blood vessel in his brain broke. This was the best understanding of cardiovascular medicine at that time, is that things like stroke happened as a bolt from the blue, unpredictable, could not figure out why it happened. Interestingly, the president, despite having no less than 3 physicians, his official records as leader of the Free World Commander-in-Chief, his military records have disappeared. We don't have his medical records anymore as official government record. The only record we have is from his private cardiologist, Howard Brun. And Howard Brun noted the following observations, which have been turned into a graph. Years along the x-axis from 1935 to 1945 with a break in it to show you added detail. And on the y-axis is his blood pressure. And punctuated by things that all of us have on our life schedule, including D-Day, election, Yalta, but also things like LVH on EKG, proteinuria in our urine. But you might notice that the president's blood pressure was, let's say, unhealthy for some period of time, up into the 200 over 100 range. Hopefully you all recognize that that's not healthy. But at that time, it wasn't quite clear whether it was healthy or not. And it was in direct response to what happened to President Roosevelt that the government decided, were there ways that we could predict who was going on to have a heart attack or a stroke? Were there ways that we could predict that those were going to occur? And so from these, we wanted to make some definitions. What is CVD? CVD or ASCVD is atherosclerotic cardiovascular disease. That's the kind of thing that they were trying to predict. They identified a possible thing to examine, which were cholesterols or lipids, which are blood fats, but because fats are non-soluble in water, They're packaged by proteins for solubility and for docking of various enzymes to help break them down. Total cholesterol is the combination of good cholesterol or high density lipoprotein cholesterol plus LDL plus 1/5 of your triglycerides. This is the Friedewald formula that most of us use when we're ordering a fasting cholesterol level. Hypercholesterolemia or hyperlipidemia generally is driven by high LDL. If your LDL goes up, holding everything else the same, your total will end up going up. Dyslipidemia, however, is the combination of high triglycerides and low HDL with small dense LDL. We don't measure small dense LDL very well because small dense LDL doesn't take up much space in the deciliter of blood that we're measuring. Triglycerides, you could imagine, can go up by less than the HDL goes down, thereby not changing the total that much, but certainly being dangerous and a risk factor. And so that's what we technically call dyslipidemia. So this is the slightly nerdy difference between hyperlipidemia and dyslipidemia. So what the studies funded by the government through the National Institutes of Health helped us establish was this paradigm, that there are risk factors for the development of atherosclerotic cardiovascular disease risk factors, which change things in the body like arteries, hearts, make them thicker, make them stiffer, make them calcified, which then eventually lead to things that people actually care about, including heart attack, stroke, and heart failure. This is the paradigm that's been proven to be quite effective in addressing cardiovascular disease in America and around the world. So what did the NIH-funded cohort studies, including the Framingham Heart Study, and the CHS and the Railroad Health Study and various other studies found that these factors were very important in predicting your risk of ASCVD, including, in order, age, sex, systolic blood pressure, total cholesterol, good cholesterol as a reverse risk factor, that is, the higher your HDL, the lower your risk, smoking, and diabetes. All of these put together are able to predict your likelihood of going on to have a cardiovascular disease event in the next 10 years by about 77 to 78%. All of the money spent since then, including to people such as myself who've gotten grants, all of that put together adds maybe another 1 to 2% to the risk prediction, which makes us feel a bit humble and should make us feel a bit humble on the importance of these as the dominant risk factors. I'm going to let you in on a little secret. Recently, we've been winning. Looking at deaths from heart disease starting in 1900 to about 2011, you can see there was a maximum around 1980. And since then, we've been winning the battle. We've been having fewer and fewer people dying from heart disease. And that's a great thing. But the problem is, that's not the whole story. Most recently, in the past couple of years, we've had a plateauing of this number in mortality. And overall, the number of people having a cardiovascular event has not declined. We're just getting better at saving their lives. How have we saved their lives? Well, this is a modeling study looking at several countries around the world where they divided the number of lives saved into prevention before they've had an event. That's called risk factors in the light blue, and treatment after a person's had an event. That's in the dark blue. And what you can see in every one of these countries, the bulk of the lives saved was in risk factor modification before they've ever had a cardiovascular event. That's where we've saved their lives. Whereas the dark blue, the thing they don't tell you about the dark blue on this graph is the bulk of the dark blue is also from risk factor modification after the fact. So that is to say, nearly 70% of the lives saved in each one of these locations has been due to modification of risk factors. Our colleagues in the cath lab and in the operating room are responsible for less than 15% of the lives saved. So this underscores the importance of risk factor modification. And perhaps the importance of risk factor modification throughout the life course. Still, it's important for me to point out the U.S. Preventive Services Task Force reiterated in 2023 similar findings to what they found in the past, which is that screening for lipid disorders in children and adolescents younger than 20 years of age has insufficient evidence. It's given an I statement. In other words, there are not yet sufficient data demonstrating modification of lipids from childhood prevents cardiovascular disease over the next 40 years. I've been trying to get 40-year-long grants from the National Institutes of Health, but those are not forthcoming. So if that's the case, why should we even be having this session? What I'm going to try to prove to you is the epidemiological burden of lipids, the life course damage that lipids can cause, and the effect of lipids on those subclinical phenotypes that we were talking about earlier. So data from many years ago and is still being repeated and demonstrated is that nearly 1 in 5 of general population children and adolescents between 8 to 17 years old, 1 in 5 have abnormal cholesterol. So let's compare that to some of the other things that are dealt with. Autism is on something like 1 in 80 to 1 in 50, depending on sex. Something like Down syndrome is 1 in 1,000. So lipid disorders in kids gives a run for your money for some of the most common conditions that we deal with in pediatric medicine, almost as common as asthma. So what about trends? There's some very counterintuitive trends that have been happening over time. When we look again at the nationally representative NHANES data, if we extend back to 1988 all the way until 2016, we'll notice that the proportion of kids, as all of you know, who are overweight and obese has been increasing steadily over time. Having said that, what's interesting is that the proportion with high cholesterol has actually decreased over this period. I'm going to say that again. As obesity has increased, high cholesterol or abnormal cholesterol has actually decreased. The exact reason for this is not clear. Well, one possible mechanism would be, what if it's because of that dyslipidemia problem that we were talking about earlier, that it's because HDL is going down due to obesity, and that's why our total is going down. Well, that's not the case. The proportion with low HDL that you can see here has also decreased. But the other takeaway from this slide that I think is very important is the proportion of kids who have high cholesterol or abnormal cholesterol who are normal weight is nearly 40%. So I'm going to again say that one more time. It is certainly the case that being overweight doubles your risk. It is certainly the case that being obese triples your risk. Does that then imply your risk in normal weight is 0? Answer, no. The actual numbers are roughly 10%, 20%, and 30%. It turns out that 10% of the normal weight population is a large number of kids. So when you flip the statistic around in the other direction and you say, I care about high cholesterol, what proportion of those kids with high cholesterol are normal weight? It turns out that it's nearly 40%. And the important implications for that are twofold. One, if you are limiting your screening only to overweight and obese kids, that's fine. Use whatever means you need to get those kids motivated, but you're missing nearly 40% of the problem. The second issue is, if it's the case that 40% of the kids are normal weight, well, is then weight loss the primary method by which we should be trying to modify this? There must be something else at work. And so that's important data, I think, for us to ponder. Okay, so what about the connection between cholesterol and actual hard ASCVD events? So this is very important data that's recently come out from a combination of cohort studies that were started in the 1970s, 1980s. 7 studies from around the world, including the Bogalusa study from this country, the Princeton studies from this country, Young Finn study from Finland, CDAH from Australia, combined forces like the Avengers and brought their data together and have followed those individuals from the 1970s, 80s until now when they're in middle age. And they've tried to determine what proportion of them have gone on to have heart attack, stroke, heart failure events, and whether the risk factors that were measured in the 1970s and 80s were predictive of whether they went on to have events. And that's what I presented for you here. And hopefully you've been able to see here that all of the risk factors that we worry about are important. Blood pressure, cholesterol, including triglycerides, total cholesterol, and in combination, they're very predictive of having a fatal cardiovascular event and a non-fatal cardiovascular event. And they broke it down by both adult-only levels, childhood-only levels, and the combination of all three. And they found that childhood levels matter, and the change from childhood levels also matter. So this underscores and gives us data that we did not have before, directly demonstrating that risk factors in childhood predict adult cardiovascular disease events independent of what happens to your adult levels. So no matter what your adult levels are, your child levels matter. This is old data looking at atherosclerotic plaque in persons who had unfortunate demise due to accidents in the PDAY study. And they found that cholesterol, units of cholesterol were predictive of plaque formation in the right coronary artery as early as 15 to 34 years old. And there's data similar to this extending down to 10 years old, and data similar to this demonstrating similar findings in persons who died as veterans early on in their lives in various wars, including Vietnam and Korea. So this has been repeatedly demonstrated that early childhood cholesterol predicts the presence of atherosclerosis in the coronary arteries. Without having to look at autopsy data, this is data showing that ApoA1, which is a feature of HDL or good cholesterol, and ApoB, which is a protein found in LDL and triglycerides, were predictive in the directions that you would expect on thickening of the carotid arteries. Thickening of the carotid arteries is an index of accumulated cardiovascular risk factors, and having too much of the bad stuff was predictive of thickening, and having a lot of the good stuff was predictive in a thinner arterial wall. So this tells us in one direction that having the risk factor predicts bad things happening to you in the future. What about a change in those risk factors? Does that have any impact? This is data from the Young Finns and the Bogalusa study comparing 4 different groups. They examined people in childhood and in adulthood, and they looked at their triglycerides or HDL. And there were 4 groups: people who had normal cholesterols in childhood and normal cholesterols in adulthood. That's the control group, that's the ideal group. Then they had people who had high cholesterol in both childhood and it stayed high in adulthood. That's the group that is persistent. That's your worst group. Then they had a group where were normal in childhood and got worse in adulthood. That's called the incident group. And then the 4th group are people who had high cholesterol in childhood, but they managed to improve it and resolve it by the time they were adults. And that's called the resolution group. And what this data table shows you is that the resolution group, who started off high in childhood but were able to resolve it by adulthood, were indistinguishable in the thickness of their carotid arteries compared to the control group. So this is indirect data that if we can get these cholesterols under control, triglycerides and HDL, if we can get those under control, that we can prevent the arterial changes that then go on to lead to important cardiovascular events. Similarly, this is data again from that I3C study that we were talking about earlier, and this is a similar concept. Normal is persistently within the guideline range. Incident means it got worse over the life course. Resolution means it got better over the life course. And persistent means it stayed high. The risk of cardiovascular events on the y-axis, age over the x-axis. And you can see that those who stayed low within the normal range were indistinguishable from those who were able to resolve themselves over time. Again, and these are hard events. These are heart attack, stroke, heart failure events. So this really underscores how important it is to try to get these things under control over time. Because these are observational studies, these were not convincing to the USPSTF task force, but I think it's very suggestive data. So that being the case, given that I've tried to make the case that this is important to look at, what are we supposed to do about it? Well, we've had recommendations to screen and manage cholesterol since almost a couple of decades now, almost 30 years, including the most recent iteration in 2011, where an important advance was made. Whereas for some time, we've been recommending screening kids with risk factors like family history and personal conditions and so on. Screening them has been recommended. In 2011, a recommendation was made to screen all kids for cholesterol around age 10 or 9 to 11, and then again at age 17 to 21, regardless of what their risk factors are. So how, over these 30 years, how good have we been in screening for lipids? This is one study that we did before the 2011 guidelines came out, looking at HMOs around the country, totaling about 653,000 kids from 2002 to 2012 in the locations listed here, to try to see how we were doing as far as lipid management was concerned. And what we found was, over this period of time, despite multiple sets of recommendations, the proportion of kids who had their cholesterols tested declined over that period of time. So fewer kids were being tested over this period of time, despite us talking until we're blue in the face. Over this period of time, however, the proportion in green who were detected with genetic high cholesterol actually increased, which seems to suggest that the screening being done by providers was more targeted. That even though we're doing less testing, we're finding more cases, perhaps suggesting that we're testing those people who are at highest risk of having genetic lipid problems, like people who have a family history or very high family history or various other things. But on this same graph, you'll notice the yellow line, which is the number of kids who are being put on medicine. And the medicines are usually reserved for those kids who have the genetic high cholesterols. And you can see that the yellow line here towards the end is not matching the green line. That gap between green and yellow is an actionable gap to try to cover those kids who are being detected with life-saving medication. The other gap on this graph is the number who should be detected, which is at the top white line here. That's the minimum number with genetic dyslipidemia, genetic lipid problems. That's the expected number at a minimum. And you can see the green line is nowhere close to that white line. So there are two actionable gaps on this graph. Why might this be? Well, a very nice survey study done in 2014 demonstrated, is a survey of providers who treat kids, both family practice and pediatric providers. And what they found was 74% of the respondents to the survey believed that lipid management in childhood would reduce future ASCVD risk. Still, nearly a third performed no screening, nearly a third were unfamiliar with the screening guidelines, 80% plus felt uncomfortable with management, and nearly 60% were uncomfortable ever using medicines under any circumstances. So these are some disturbing findings and may explain why we're not doing a better job with management. So what are the guidelines as of 2011? Starting as early as age 2, you can do selective screening on kids who have risk factors of certain medical conditions, family history of early cardiovascular events, family history of high cholesterol themselves. These would all be reasons to check if you feel like checking, and if normal, repeating the checks every 3 to 5 years, and if abnormal, managing them on the abnormal management pathway. And for these individuals, fasting levels are preferred. At the same time, universal screening is recommended around age 10 and around age 18. And these levels can be non-fasting to start off with, just to make sure that the folks get it done. And then if an abnormal level is found, then following it up with a fasting level, if at all possible. Non-fasting levels can be adjudicated on the basis of total and non-HDL cholesterols. Non-HDL cholesterol is the difference between total and HDL. It's just as simple as that. The math is just as simple as that. Is to do a non-fasting level, measure the total, measure the HDL, and calculate the non-HDL. These ages were selected due to the known life course changes in cholesterol over time. Once you get to be about 11, 12 years old and puberty starts to hit, numbers start going crazy and going all over the place. So trying to get the testing done before puberty has sort of hit and messed all our numbers up is felt to be the best time to do the 10-year-old screening. And then the 17 to 21-year-old screening is really to figure out what needs to be modified as they move into adulthood, because they've by then started to develop a more adult eating pattern, and we can try to nip problems in the bud and try to modify their lifestyle habits if at all possible. That's why those two ages were selected. What are some of the risk factors that may modify our decision to do a selective screening or to manage them differently later on? Risk factors include family history in first or second degree relatives of cardiovascular events before age 55 in males and before age 65 in females. This is very hard for families to try to parse through when they're talking to you. So what I often do is just ask for who's had an event before age 65, who's had a heart attack before age 65, who's had a stroke before age 65, who's had a blood clots or whatever. And then I figure out if they're talking about a boy or a girl. And that makes it easier for families to remember. Otherwise, you'll be there all day for them trying to figure out this three-way axis. Other risk factors that matter are hypertension, smoking, obesity, and various other risk factors. And these are some of the special risk conditions that can also change how you do what you do. Diabetes, transplants, solid organ transplants, Kawasaki disease, HIV infection, chronic inflammatory diseases, nephrotic syndrome, all of these may cause you to get screenings done earlier or treat people more aggressively. Okay, so unfortunately, we do have to have our requisite lipid slide, lipid metabolism slide. We can't go through one of these talks without at least having one slide. So we'll do that now. So when we eat, our guts find the fat and absorb that fat into the intestinal wall where it's packaged onto ApoB48. ApoB48 plus fats is called chylomicrons. Those chylomicrons float their way through the blood and find their way to the liver. They do get chewed up during that period by a protein called lipoprotein lipase. They get to the liver uptakes those fats, repackages them onto ApoB100. The combination of ApoB100 plus fats is called VLDL. It's the combination of chylomicrons plus VLDL that we measure as triglyceride in the blood. So when we measure triglyceride, it can either be chylomicrons from the gut or VLDL from the liver. Then that VLDL again goes floating through the blood where it again engages with lipoprotein lipase. And lipoprotein lipase chews up the VLDL into IDL and gives off HDL. And then finally to LDL, giving off HDL. And so one can imagine that if you put a blockade on lipoprotein lipase, you're going to have a buildup of chylomicrons and especially VLDL and less production of HDL, i.e. high triglycerides, low HDL dyslipidemia. And then whatever LDL you have doing its functions as it floats around the body gets munched on and munched on and munched on by the body until it gets to these small, dense nubbins of LDL. And so lipoprotein lipase is absolutely at the core of what we're talking about today. And we'll come back to that in a minute. So when we're looking at these numbers, what's abnormal? Total cholesterol above 200, LDL above 130, triglyceride above 130, and non-HDL above 145 are all abnormal, frankly abnormal. And the HDL we wanted above 40. So those are the numbers that we're really worried about and what I'm going to see here today in my lipid clinic. We're supposed to get at least 2 fasting lipid profiles, average those 2 numbers, just to make sure that neither one of those was just lab error. And if elevated, we're supposed to deal with in this fashion. If triglycerides are above 500, do not pass go, send them directly to a specialist. If LDL is above 250, also send them to a specialist. You're supposed to first deal with the LDL. If not one of those two things, then deal with the LDL first using the target LDL approach, which goes beyond the scope of this talk today. But basically, because LDL is more dangerous, you're supposed to deal with LDL first. Once you've dealt with the LDL and that's under control, then you deal with the triglycerides. And the first step is the target TG, child 2 TG diet. And then after doing the diet for 6 months, you check again to see where their triglycerides are. And if resolved, you just keep monitoring. If not quite resolved, do the things that are listed here. So when we're talking about lipid disorders, there are 3 major categories. One is related to lifestyle, one is related to genetics, and the final one is related to secondary dyslipidemias. It's most probably the case that even lifestyle dyslipidemias have some mildly impactful genetic variant, but is of no consequence because we primarily focus on the lifestyle as the modification approach. Again, pointing out that we're really talking about lifestyle and not obesity per se, as we noted earlier. Again, the importance and centrality of lipoprotein lipase. Again, to review, VLDL gets chopped up by lipoprotein lipase into IDL and splits off HDL, and then eventually splits off again into LDL. Interestingly, and perhaps putting everything in place, one of the key molecules that blocks the action of lipoprotein lipase in vivo is insulin. So now when we have individuals walking around with high fasting insulin and acanthosis nigricans and all those kinds of things, and overweight obesity, the insulin that's floating around blocks the lipoprotein lipase, leading to what we're talking about here. And when we have this insulin issue, it also gives us a clue on the type of lifestyle modification that's going to be most effective. The key centrality of insulin resistance cannot be overstated. This is data from the Framingham that we've constructed, where we looked at adults with low HDL and abnormal insulin resistance. In those individuals with low HDL and, with high HDL and no insulin resistance, they had the lowest risk of having a heart attack 10 to 15 years in the future. Having low HDL but no insulin resistance appeared to be very similar. Having a high HDL, meaning having a healthy HDL but insulin resistance, was a risk factor for having elevated risk of cardiovascular disease. And being low HDL with insulin resistance was the most dangerous of all. So what we're trying to suggest here is that HDL by itself was not the determinative factor. It was the presence of insulin resistance. So there is some data now very strongly suggesting that HDL and the modification of HDL by various, and similar data, I should say, for triglyceride. The triglyceride data looks almost exactly the same. Medicines that modify HDL and medicines that modify triglycerides don't directly seem to impact cardiovascular disease events in the future. They are not well demonstrated after the initiation of other standard therapies. Using medicine to lower the triglycerides don't seem to appear to improve cardiovascular disease risk. And it may be because of what you're looking at here is that both high triglyceride and low HDL are not the causal element themselves, but are simply marking insulin resistance. But again, it's more complicated than that because insulin sensitizing agents also don't prevent cardiovascular disease directly. So the situation is very complicated. Nonetheless, what we do know, and what you saw on the slides that I noted earlier, is that resolution over the childhood life course of high triglyceride and low HDL, the resolution of that did seem to be protective. And since in the vast majority of kids, it's not medication that we're using, lifestyle is just so important. And so the NHLBI guidelines demonstrate that after doing the things here in the first bullet point that address LDL as your baseline, then we should start to focus on triglyceride specific issues. And this is specifically around carbohydrates. So there's two ways to try to modify the insulin. One is to decrease total carbohydrate load, and the other is to modify glycemic index. And there was a very nice trial in adults called the OmniCarb trial that proved that it was total carbohydrate load that appeared to be the most important. Having said that, low carb diets are not effective, as you all know, because they're effective for the time that you're on them for a few months, but then most people have to have their pasta. And then once they start eating their pasta, they start overeating their pasta, and then they start yo-yoing and feeling worse about themselves. And so that's simply not a sustainable approach. And the other problem is that most people, when they say they're doing a low carb diet, are not actually doing a low carb diet. Keto is not what we always know as keto, right? People understand those words differently and implement them differently in free living situations. And so what we find in our clinic is a more effective approach is to ask folks to change the type of carbohydrates that they're eating, to try to change them to more whole grain products, like whole grain breads, whole grain pastas, whole grain noodles, whole grain tortillas, brown rice or quinoa instead of white rice, sweet potatoes instead of white potatoes, with the hopes that the increased fiber, increased bran, increased elements present in the whole grain will naturally reduce the amount of carbohydrate that they're eating. And also, incidentally, changes the glycemic index at the same time. So you get both birds with one stone without taking them away. So you can tell folks, yes, you can have your spaghetti, but make sure it's whole grain spaghetti. And what will naturally happen is they'll end up eating less spaghetti because you can't eat as much brown spaghetti as you can white spaghetti. I double dog dare you. You can't do it. And so they get more satiety, but without feeling like they're being restricted. And we find tremendous success with that approach. The other things that are very helpful are increasing lean protein intake, especially in the form of cold water fish or fatty fish or predator fish. Of course, the predator fish, you also have to take into account possible mercury contamination. And so that's something important to counsel them on. And another key piece of this is the complete elimination of sugared beverages. That's probably one of the highest yield changes that you can make, is trying to get them to get off the chocolate milk at school, the smoothies and the juices at home, all of it, trying to reduce all sweet tea, reduce all of that or eliminate it as much as possible. That small change on a daily basis can make huge changes on their triglyceride levels. And then finally, cruciferous vegetables are probably important all the way across. And when I say cruciferous, nobody knows what I'm talking about. So we're talking about crunchy vegetables. So how effective is that approach that I was just describing? Well, some data that we generated a few years ago in persons with in kids in clinic using a clinician delivering the approach that I just said and the availability of a dietitian in clinic, was able on average to reduce triglycerides by 27% on average. But I can tell you from personal experience, I've had kids do 50%, 70%, 90% with this approach that we just described. I've had a youngster in this very clinic where I am in Satellite today who had triglycerides of 900, who brought it down to 150 in 3 months using the approach that I was just talking about. And the reason I believe it as an N of 1 is that a year later, she went off the diet and her triglycerides went back up again. I said, you went off the diet, didn't you? And she said, yes. And she went back on and it brought it back down again. So just the power of how important these changes are. And we should expect about 36% of these kids to normalize their triglycerides using this approach. Now, the numbers that I've just quoted to you are with or without weight loss. If we can get weight loss or weight stabilization, that's great. And that often happens when you start to reduce total calorie intake due to reduction in carbohydrate intake. But even without weight loss, these changes obtain. Okay, so what about the more severe forms? There is something called genetic familial hyperchylomicronemia. It happens in 1 in 500,000 to 1 in a million kids. Onset is in childhood. Triglycerides are often above 1,000. The risk of CVD is unclear because they have such a high risk of pancreatitis at any given time. The genes that are implicated all belong on that same enzyme pathway that we were talking about earlier. So chylomicronemia, hyperchylomicronemia from a genetic perspective is often the genetic absence of lipoprotein lipase, or the absence of one of the proteins that lipoprotein lipase uses to dock to the chylomicron. ApoC2, ApoC3, ApoA5, various other proteins, all of which belong in that lipoprotein lipase pathway. ApoB levels can be normal or low. Contrast that with familial hypertriglyceridemia. This is an elevation of VLDL. This can affect up to 1% of all general population persons. Onset is often in adulthood and can be multifactorial and can be very complicated. Triglycerides can be above 500 and are often above 1,000. These individuals do appear to be at higher risk of cardiovascular disease, but also at risk of pancreatitis. And more than 45 genes have been implicated in this pathway, but many of them, again, are on that lipoprotein lipase pathway and a few on other pathways. And here, the ApoB levels, which is the protein that's attached to these bad cholesterols, is often high. So just to recap these two things, familial hyperchylomicronemia is very rare, 1 in 500,000 plus. Dysfunction of lipoprotein lipase, often due to genetic absence, implicating these genes, whereas familial hypertriglyceridemia is much more common and much more variable in its presentation, often being triggered by either obesity or alcohol use or various diabetes in adulthood. But many of these same genes are implicated, and the exact genotype-phenotype correlation goes beyond the scope of this talk today, but I'd be happy to chat with you about it if you're interested. As a little bonus, for those of us who don't have ready access to fancy labs, there is a quick and dirty way of trying to figure out which of these things it is. If you take a patient's sample of blood and you put it in the fridge overnight and you come back and it's clear, it started off looking like a strawberry milkshake. That's how you know their triglycerides are very high, often over 1,000. If when you come back in the morning, the blood has cleared, it's settled out, it's very often chylomicrons. If you come back and it looks cloudy, it's probably VLDL. And if you come back and it still looks like milkshake, it's probably some combination of the two. This is a quick and dirty way that we used to do this in the past. There are more advanced ways of doing it now. And ApoB is probably a near facsimile that most of us can have access to using commercial labs to figure out which of these is going on. ApoB being high in the high triglyceride form, ApoB being normal or low in the chylomicronemia form. So secondary etiologies, what kinds of things do we need to be thinking about that the triglycerides are simply marking some other problem? Thyroid disease is an obvious one. Nephrotic syndrome is another obvious one, but it can include all these other things that you see listed here. The use of anti-inflammatory or chemotherapeutic agents, immune suppression agents, the presence of diabetes. Several of our patients here at Texas Children's that present with severe high triglycerides for the first time, it's actually their presentation of diabetes. And so thinking about that, I think, is very important. Various metabolic disorders, often presenting early on in the lifespan, like Niemann-Pick syndrome, Tay-Sachs, glycogen storage diseases, and so on. Inflammatory conditions can cause insulin resistance and direct inhibition of lipoprotein lipase. So inflammatory conditions can sometimes be important mimics of high triglyceride, as well as direct liver damaging diseases. And some things that we're noticing in more recent era are environmental exposures, especially serious environmental exposures or latent environmental exposures may be predisposing, especially endocrine disrupting chemicals like PFASs and bisphenols and various things like that appear to be related to both dyslipidemia and endocrine disruptions. And so this might be an emerging area that requires more study. So let's talk about pharmacotherapeutics. So one of the recommended medications is omega-3 fatty acids. Omega-3 fatty acids include ALA, EPA, DHA, and it appears that the omega-3 to omega-6 ratio appears to be critical. The mechanisms go beyond the scope of this talk, and are sometimes associated with 25 to 45% reduction in triglycerides in adults. But this is controversial. The first couple of studies done showed that omega-3 use appeared to be protective against cardiovascular disease. The subsequent 5 or 6 have been shown to be negative results. It does not appear to prevent cardiovascular disease in an important way, except for one trial called the REDUCE-IT trial, which only looked at EPA, isolated EPA, which appeared to be effective. But there was something funny going on with the placebo group. And there's suspicions that the placebo group may have been taking a form of, the placebo itself may have been a dangerous issue. So it wasn't that the EPA was helpful, it's that the placebo was harmful. And pediatric trials that have been done with omega-3s have been found to be negative. It did not seem to improve triglycerides. Having said that, it appears to be low risk, low danger, and oftentimes we'll use it just to see if it helps. But it's not clear whether it's helpful in all cases. And there are some purported risks related to increased atrial fibrillation in adults and interfering with coagulation, and it doesn't taste good when it's coming back up. So these can all be problems. One of the key medicines that's often thought about or used are fibric acid derivatives. These are things like fenofibrate or gemfibrozil or bezafibrate. These medicines help rescue lipoprotein lipase by rescuing PPARs, peroxisome proliferator activated receptors, especially PPAR alpha and PPAR gamma. These PPAR rescues then rescue lipoprotein lipase and downregulate the docking proteins ApoC3 and so on. Now, this is important for people who have usual lifestyle-related inactivation of lipoprotein lipase by insulin. Maybe those individuals can be helped with fibric acid to help reduce their triglyceride levels. But what if you have a genetic absence of lipoprotein lipase or a genetic deficiency of one of the proteins that lipoprotein lipase attaches to? Then these medicines are not likely to work. And so those individuals that you see with triglycerides above 1,000 or 2,000, the ones that are at the most risk, the ones that you want to help the most, are actually the ones that are likely to be the least helped by these very same medicines. So it's a bit of a catch-22 type of situation. These medicines can have a powerful effect on the triglycerides, and this has been well demonstrated. But in adult studies like FIELD and ACCORD, fibrates, in addition to standard of care cardiovascular therapies, did not significantly reduce the coronary events. So whether or not they're really effective in doing anything than changing the number is controversial at this time. And they do have adverse effects like liver damage, gallstones, myalgias and myopathies, which can then lead to kidney damage. And again, like the other one, like omega-3 is technically not approved for youth. Niacin is another medicine or a vitamin, whatever you want to call it. It improves triglycerides, HDL, LDL, and lipoprotein A. Its mechanism of action is a bit mysterious, so I won't go into that too much. But it does appear to have powerful effects on triglycerides. And it does appear to prevent cardiovascular disease events. But the mechanism by which it appears to reduce cardiovascular disease events is precisely proportional to how much it reduces LDL, not in relation to how much it reduces anything else. And nearly 10% of users will have side effects, including a flushing feeling, causing diabetes, causing myalgias. And so 10% side effect risk is actually a huge number for a modern medicine. And again, it's not approved for kids, but it is available over the counter. So folks might use it anyway, with or without your approval. An important thing to note is that the FDA recognizes that a common combination of medicines in the literature is statins plus fibrates or statins plus niacin. But the FDA in 2016 withdrew their approval for these sorts of combinations, finding that there was not sufficient reduction in cardiovascular disease events to justify this. And the side effect profile was much higher. The combination, so statins can cause myalgias and rhabdomyolysis. The addition of niacin or the addition of fibrate to that increases the risk of rhabdomyolysis tenfold. So the tenfold increase in rhabdomyolysis plus the risk of downstream kidney damage from that versus zero improvement in cardiovascular disease risk made the FDA withdraw their approval for this combination. So this is important for folks to think about. It's still done. I know the adult world does it, and some of my colleagues in pediatrics do it as well, but the FDA officially has put a black box on it. So if you're going to do this, do it with your eyes open. So let's come back to our patient. When we repeated the labs, we found that her liver was even worse, her cholesterol got worse, her HDL got worse, and now her triglycerides went up to 840. Now, as you noted, from the fact that she's gotten to this age, she's otherwise well appearing, has no evidence of any other systemic diseases, but also doesn't have overweight obese despite having what sounds like a couple of episodes of pancreatitis in the past. That made me feel like she was as wrong as a $3 bill. And so what I suspected was to look for liver disorders. And one of the liver disorders that I tested for was Wilson's disease. And in fact, her urine copper was almost undetectable and her serum ceruloplasmin was also indetectable. And therefore, she was diagnosed with Wilson's disease at age 11 before any of the neurocognitive or liver issues had set in. The detection of her triglycerides is what led us to this diagnosis. She was started on therapy for Wilson's disease, and she's currently, actually I should update this, she's currently 20 years old, completely neurologically intact, no Wilson's disease sequelae. She did go through teenage years, and she was a teenager and decided that she didn't want to take her medicines for a while, got into some risky behaviors and various other things, but is back on track now with somewhat modestly controlled triglycerides and is doing well otherwise. So some final take-home messages. Abnormal cholesterols in children are prevalent, detectable, but a large proportion of them are normal weight. So just keep that in mind when you're thinking about your testing and your screening. At the same time, the USPSTF gives lipid screening in kids an insufficient recommendation. Not enough at-risk kids are being detected. The detected kids are not being treated, and lifestyle modification is challenging to sustain, but can be effective. And so a couple of questions, and maybe if you'd like to answer in the chat, you're welcome to do so. At what age do the current guidelines, AAP and NHLBI guidelines, recommend universal lipid screening for children and adolescents? Your options are A, B, and C. So if you wanted to put in the chat what your answers are for number one, I'll let you put those in there. Another question, what proportion of youth with high triglycerides are also normal weight? So you can put in there 2A or 2B or 2C, whatever you feel like your answers are. And then finally, dietary modification to address high triglycerides should focus on changes in overall calories, overall salt, or the modification of carbohydrates. So this is also something that I think is very practical for your clinic. And so you can put those answers in there if you like. I'll give everybody 20 more seconds to put any answers they like, and then I'll give you the answers. So I know we all like to know if we were right or wrong. So we'll go back to question number one. Okay, so for question number one, the answer is B, between ages 9 and 11 and 17 to 21. So around age 10 and around age 18. Pre-puberty, and then right before they're going to leave your clinic. Question number two, somewhere around 25 to 50% of kids with abnormal cholesterol are normal weight, depending on the cholesterol type. And finally, and modification in simple carbohydrates is probably the most effective method compared to these other two of trying to improve. Here are some references if you'd like to read more on your own. And with that, I'll stop this talk and happy to take any questions for the last minute or so. Thank you,
Dr. Zach.
Opportunity.
Thank you, Dr. Zachariah, for that wonderful presentation on hypertriglyceridemia. There is a question. I have heard it said that if all of us were forced to be vegan, right, without processed oil or sugar, there would be virtually no cardiovascular disease. Comment.
So this is a very interesting comment, and thank you for the question. I would say that in free living individuals with choices, this is an impractical suggestion. Having said that, there are societies around the world um, and ancient societies who have lived on a more agrarian diet where meats and various oils and things were luxuries that they could not afford or did not have access to. Atherosclerotic disease still appears to be prevalent in those. And I'll point your attention to some recent CT scan data from ancient Egyptian mummies, including of non-pharaonic mummies, demonstrating coronary calcium in those individuals. And I think that what probably happens is the vast majority of our calories in the diet come from carbs. The average American diet, and this is true around the world, I think also, 50% plus of our total calories come from carbs. And if we refine our carbohydrates, simple refined carbohydrates are associated with these triglyceride levels and then eventual problems. So it's not simply an issue of simple sugars or oils. Refined carbohydrates are also an important problem. There are other societies around the world. I'm thinking about ones that live closer to the Arctic Circle that have low carbohydrate intake, higher protein and fat intake, who don't appear to be at that much higher risk of cardiovascular disease. So I think it's challenging to know what this hypothetical might actually turn into. But I thank you for the question.
Any questions, comments? Dr. Lynch liked your talk. He says, fantastic talk. Thank you.
Thank you, Dr. Lynch.
Any other questions, comments for Dr. Zachariah? Has anybody looked at cost effectiveness of this AAP recommendations starting at 2, then around 10 and 18? How cost effective it is in preventing cardiovascular disease?
There are a couple of studies out there. I think the most recent was by Adrian Moran, Moran, about trying to look at earlier screening. And then there have been others in the past. One of the senior authors, I think, was Matt Gilman, Gillman, looking at lipids, blood pressure, various kind of screening modalities. And the problem here is the effectiveness of intervention for these things is not well enough established. In other words, we don't exactly know how much our modifications on a population basis should reduce the levels. And until 2022, 2023, when the I3C data came out, we didn't quite have the life course approach. So if you have this level of triglyceride in childhood, what's your risk of event in adulthood? We just recently got that data. So we don't yet have the updated data on cost effectiveness. We don't yet.
Thank you. There's a question from Dr. Lipset. How accurate is a calcium score?
Okay, so this is a very good question. So I would say that calcium score, age matters and a priori risk matters. So what we know is, let's take middle-aged people. We know that middle-aged people, calcium score can help either up risk or down risk your likelihood of cardiovascular disease. But there is a caveat to that, which is long distance runners, marathon runners, ultra marathoners appear to have very high calcium scores. But these same individuals are sort of the picture of health, at least most of us would think. So there's something funny about their remodeling and something that they're doing to their bodies, that their calcium score is actually misleading. And so when you start extending calcium scores to younger kids, it can be very misleading also. If they had, let's say a 16-year-old track and field athlete has a high calcium score, do we think that they're like their middle-aged parent, or do we think that they're like a middle-aged marathoner? It's hard to know. Moreover, kids can have important plaques, but not yet have had the time for it to calcify. And so when we start to look at this, it becomes very confusing at younger age groups, and that's why we don't generally use it. Coronary calcium at younger age groups tends to have so much variability that if you see a calcium, maybe it's like a healthy calcium, And if you don't see calcium, that's not necessarily reassuring. They could have a huge plaque and it just hasn't had time to calcify yet. And so that's kind of why we don't use calcium scores very much. So the accuracy in young people, I think, is problematic. I think the accuracy in adults has been demonstrated.
Dr. Zachariah, thank you very much for that wonderful presentation on diagnosis and management of high triglyceride. Thank you all for attending this morning's round. I'm going to conclude and have a wonderful Friday and wonderful weekend. Again, Dr. Zachariah, thank you very, very much for
Thank
this
you all for the
morning's
invitation.
presentation.
Have a great day.
Okay, thank you.
Bye-bye.